So as mentioned in the last talk, the last major position or consensus paper on heart rate variability put out by a major medical professional society was in 1996. And there were only 2 clinical indications for heart rate variability mentioned in that position statement. And they were post-myocardial infarction and diabetic neuropathy. So that makes my job easy because there was only 2 conditions that really for where heart rate variability was indicated. And so I'll go into that in a little more detail. And the thing that many were focusing on during this time was sudden cardiac death. Now, any clinician who takes care of patients will appreciate the significance of sudden cardiac death, which is often attributed to abnormal rhythms such as this is ventricular fibrillation. I remember my first case when I was a medical student. There was a portly gentleman who came in to the coronary heart care unit, and we were rounding on this patient, and this patient was very angry about, being in the hospital and having to stay in this unit. And while he was talking, all of a sudden his eyes rolled back, he fell back onto the bed and basically was in VFib arrest after he got his heart attack. And after that, I have never minimized the importance of ventricular fibrillation. And this accounts, ventricular fibrillation or sudden cardiac death accounts for half the deaths of coronary heart disease in the United States, and often occurs outside of the hospital or in the emergency department within the 1 hour of symptom onset. So you can see this is the normal sinus rhythm, and then this really fast rhythm, which impairs the ability of blood flow to the brain. Now, this sudden cardiac death often occurs after a heart attack or a myocardial infarction. And you can see that it often occurs right after or immediately in the sort of the few days after a heart attack or myocardial infarction. And you can see that the prevalence is much higher in the first month, and then slowly goes down over a period of months to years. This graph actually divides into categories of ejection fraction. So after you have a heart attack, and if it's a significant heart attack, you can impair the pumping function of your heart, and it could go down as low as less than 30%. What's normal is around above 55%. So clearly, if you had a larger heart attack, then you have higher chance of developing sudden cardiac death. And it is believed that some have argued that you can divide these categories into 3 parts: the acute phase, which is about 40 days after the heart attack or myocardial infarction; subacute, which is about 40 days to 6 months; and the remote, which is more than 6 months. So how does the autonomic nervous system play into studying cardiac death, and why is this important? And they had studies done in the 1970s, done by Dr. Lown, who's a renowned cardiologist from Brigham, is that they took dogs, unfortunately dogs, and they measure their EKG and subsequently introduced 3 pulses, what they call the RT pulsing. And on occasion, the RT pulsing will lead to nothing, that the EKG will return, the heartbeats would return as normal. And in some cases, this would lead to ventricular fibrillation. And what he was able to do was he would actually be able to stimulate the sympathetic nervous system by finding the sympathetic nerve, or specifically the stellate ganglion, which is part of the sympathetic nervous system, stimulate that, and you can see that this is a normal rhythm, and then it induces ventricular fibrillation. And pressure control just means that the pressure was controlled, because sometimes when your blood pressure is increased, it sort of reduces the sympathetic nervous system. But you can see that when the sympathetic nervous system was activated, there was a higher risk of ventricular fibrillation. And on the flip side, the parasympathetic nervous system has a protective effect. And this graph showed that, again, from Dr. Lown in 1977. When you do an RT pulsing, and then after about 50 milliseconds, your ventricular fibrillation threshold significantly decreases. And then after a while, it sort of returns to normal. However, when you do a stimulation where you activate the sympathetic nervous system, it reduces the ventricular fibrillation threshold even further, and then the duration is longer. So the chances of developing ventricular fibrillation persist longer than without the sympathetic nervous system, and then slowly returns back to its baseline. And then if you stimulate the vagus nerve, it reverses essentially this effect, and that you basically return the baseline. So the sympathetic nervous system enhances the possibility of ventricular fibrillation or sudden death. The parasympathetic reverses that. And these are studies that were done in dogs. Again, at baseline, this was sort of the control. You had closed evaluation of the heart rhythms. When they did an open thoracotomy, basically surgery to access the heart, you had the ventricular fibrillation threshold decrease. And then the vagal stimulation subsequently returned. In fact, it sort of even further reduced the chances of getting an abnormal rhythm or VFib. This stimulation directly caused, again, reduction of the VFib threshold. Vagal stimulation addressed that. Same with norepinephrine infusion. But interestingly, administering beta blockers, which antagonize the effects of the sympathetic nervous system, it essentially eliminates any of these interventions, and it sustains this ability to protect against ventricular fibrillation. And the vagal stimulation does nothing to change that. So the vagal stimulation reverses what is at higher risk of the sympathetic nervous system, but it basically doesn't enhance it above what, basically it sort of reverses the sympathetic nervous system's effect on ventricular fibrillation. This is another study. This was also done by Lown at that time. I wanted to add this on just because I found it interesting, was that stress really was an important factor for reducing the threshold for VFib. This was an unfortunate experiment where dogs received a Pavlovian conditioning, basically electric shock daily at each experimental period for 3 successive days, so that when the experiment started on the 4th or 5th day, they were already stressed. And, this is pre-stress. And then when they did the evaluation to see this RT pulsing, to see whether it stimulated or induced ventricular fibrillation, stress certainly enhanced the possibility of developing VFib, but the administration of the beta blocker reversed that. And he also had a very interesting anecdote of a patient who was very nervous right after her heart attack. And this is the number of ventricular premature beats. These are these extra beats that come from the ventricle, which can be a precursor to ventricular fibrillation. When they stopped lidocaine, which is a way to stop arrhythmias, the number of ventricular premature beats increased. But then when she meditated, the numbers, these ventricular premature beats decreased. And then lidocaine restored basically the normal heart so that you weren't at higher risk of developing these fatal arrhythmias. So even in the 1970s, the importance of stress meditation was already understood. And it's surprising to many of us, this hasn't really been emphasized in the 1980s or 90s. And so they understood as early as the 1970s that the autonomic nervous system is an important component of developing ventricular fibrillation. So how do you evaluate autonomic nervous system? And I felt that this was important to sort of take a little bit of a side note or explanation of how we normally evaluate autonomic nervous system and why heart rate variability has ultimately been the one that many have gone to. And this is a good illustration of the autonomic nervous system. You have basically the two systems, the two branches of the autonomic nervous system depicted here, the parasympathetic and the sympathetic on the bottom here. Both have two sets of neurons in series, a preganglionic neuron and then a unmyelinated postganglionic neuron. And you can see that the neurotransmitter that's responsible for the parasympathetic nervous system is acetylcholine. both at the ganglion and at the target tissue. Whereas for the sympathetic nervous system, it's acetylcholine at the ganglion, but largely it's norepinephrine at the target tissue. The exception being the sweat gland. And this is sort of an interesting difference about sweat glands that I don't know why it was evolutionarily developed that way, but we know in medicine that if you're exposed to a dangerous fatal toxin such as sarin, which was something that was released by a group or this cult in the 1995, they released it in Tokyo subway. And the sarin is an acetylcholinesterase inhibitor. It basically prevents the breakdown of acetylcholine. And what we saw was a lot of the parasympathetic changes attributed to this, significant rise of acetylcholine. You had salivation, you had tearing, diarrhea, bronchoconstriction, constriction of the pupil, sweat, and then all of that, which is attributed to the parasympathetic nervous system. But then you also saw sweating, because even though sweating is not part of the parasympathetic nervous system, you have the acetylcholine being responsible for how the sympathetic nervous system operates at the sweat gland. So how do you evaluate the autonomic nervous system? The way I've divided it is into two parts. You can directly assess the autonomic nervous system, either by measuring exactly the activity in these nerves, or measuring the neurotransmitters, or you could actually visualize it, or you have the indirect assessments, basically the end results of the sympathetic nervous system. And I could go into a little more detail about the direct nerve activities, the sort of direct assessments. First, you have direct nerve activity assessments, something called microneurography. For the sympathetic nervous system, you introduce a needle electrode into a nerve and then subsequently target a sympathetic nervous branch in that, or a nerve bundle within that nerve. And it's oftentimes the nerve that's chosen is the peroneal nerve. I've had this done on myself. It's not comfortable. It's also very difficult to find the exact nerve. And also there are different branches within the nerve. So you have to target the muscle sympathetic nerve. Sometimes you target the skin sympathetic nervous system. But you can see here, this is the heart or the EKG. This is blood pressure. And then you could see the sympathetic nervous activity, and you can see some of the heart rhythms, and you could also see a respiratory component in here as well. And then there's also direct assessment of the vagal nerve. They've only done this recently in the 2020s, and the only reason they've done this in humans recently is because it's a very hard nerve to access. Basically, it's right next to the jugular vein and the carotid artery, and they really needed the ultrasound to visualize and make sure that the needle wasn't penetrating one of these, dangerous arteries or veins. And you could see the activity of the vagus nerve, and then when you do a root mean squared, you could see the activity of the vagus nerve here. Then you could assess the neurotransmitters directly, either by collecting true blood tests or urine tests, and assess for the catecholamines that are in the system. They're often norepinephrine, dopamine, these other compounds. And then you could do radiolabeled noradrenaline, spillover tests. I'm not going into too much detail of that, but you administer a radiolabeled noradrenaline. Some of it gets absorbed into the nerve, and then some of it gets excreted. You could do a calculation to assess the activity of the sympathetic nervous system. Or you could do what's called an MIBG scan. You inject this radionuclear or radiolabeled compound chemical called MIBG. It gets absorbed in the sympathetic nerves. And this is an image of a person who is normal or healthy. And you can see that the MIBG accumulates in the heart. A lot of it accumulates in the liver. But a person with an autonomic nervous condition has no absorption of this into the heart. So it indicates that basically there's hardly any active sympathetic nervous system in the heart for this individual. And then the last direct assessment is to actually do a skin biopsy. And why skin? It's because there are three areas where the sympathetic nervous system clearly has an influence. One is the Ectopy muscle. When you are nervous, or it's like getting goosebumps, and it causes the hair to rise. The other place is the blood vessels. The sympathetic nervous system innervates the blood vessel. And then the last one is the sweat glands, as I had discussed before. So when you take a biopsy of the skin, you can actually take a look at the nerves, the sympathetic nerves, which is labeled here in green. And this is a comparison between a healthy person and on the left side compared to a person with diabetic neuropathy. And you can see that the sympathetic nerve is intact in the sweat glands for the healthy person, not so much in the diabetic neuropathic patient. Same with the Ectopy, and then for the blood vessels, you could clearly see that difference. But these are clearly invasive approaches. So you want to take a look at indirect assessments because that's more practical. And the way we do that is to take a look at these end organs, basically where the parasympathetic and the sympathetic nervous system acts. And we see that the pupil has both parasympathetic and sympathetic nervous system. The heart does as well. Sweat gland is uniquely at the sympathetic nervous system. But and then also the parasympathetic nervous system is important for the the gastrointestinal tract and the urinary system, but I didn't include it here. Now the question is, where's blood vessels for parasympathetic nervous system? Does the vagal nerve innervate or affect the blood vessels? And the answer is actually no. There is hardly any parasympathetic nerve innervation of the blood vessels, particularly of the arteries. There are some exceptions. There are some innervation of the facial vessels, of the coronary arteries, and then also genitalial vessels, so that a lot of the erectile function is dependent on parasympathetic nervous system. And this is important to know because this is how we could differentiate what's happening in terms of the parasympathetic sympathetic nervous system, because most of the vascular contraction or dilation is mediated by the sympathetic nervous system. So what are the indirect assessments? You have in most hospitals an autonomic lab or an autonomic testing lab. This is a picture that I took from YouTube, and it has a number of devices, and you had something called a tilt table test. And what they do in these labs is you are connected to a lot of these measuring devices, but then you introduce a lot of these provocation interventions. Valsalva is a type of maneuver, deep breathing, isometric hand grip, cold pressure, mental arithmetic, active standing, tilt table step, rare reflex sensitivity. I'm not going to go into details about that, but when they do that intervention, they are continuously assessing heart rate, blood pressure. In this case, they measure end-tidal CO2, which is carbon dioxide, and then cerebral blood flow. And this is the normal response when you do a tilt table. Basically, a person's flat, and then as you are measuring these heart rates and blood pressure, you slowly elevate the person to an upright position, and you can see that the heart rate increases, the blood pressure remains stable. However, in this person who has neurogenic syncope or loss of consciousness or fainting, what happens is that as you're slowly tilting up, you can see that the blood pressure drops down. The heart rate tries to compensate, but at some point it fails, and then the heart rate drops down, and the person basically loses consciousness. So this is something that you could evaluate with these autonomic tests. And then you have indirect tests, again, of sweats. You have the thermal regulatory sweat test, where they apply a dye, which it's called quinazerin. It's a powder dye that you apply to the front of the ventral side or the front side of a person, and you apply it all across the body. So it's an inconvenient test because you have to strip down, and then it changes color. It reacts to the sweat somehow, and it creates this purplish color. And so this is a normal response. However, in a person with multiple system atrophy with autonomic neuropathic problems, you can see that the lower parts of this person's body and some parts of the upper body were not functioning well. The sweats just simply weren't functioning. So it indicates this is a marker of autonomic nervous dysfunction. Another sweat test is electrodermal activity. This is something that you could use using a watch. This is the Sympathetic E4 watch, which measures electrical skin conductivity with time. And you can measure it, and if there's any stressful event, you could see a quick rise in the conductivity. And the final sweat evaluation test is something called QSART. Again, I'm not going to go into too much details, but it's a complicated system that can only be done in the laboratory in the hospital. You introduce electrical stimulation to the skin into the system where it has acetylcholine. The acetylcholine stimulates the sweat duct here, but that there is a back or antidromic and then orthodromic response so that the adjacent sweat glands respond accordingly. And then you will see that they will apply this to multiple parts, usually in the forearm, proximal leg, distal leg, and the foot. And you can see the response. And if you have problems in the lower leg, you will, for instance, not see this rise when you're introducing the acetylcholine. So these are the indirect sweat activity. The final one is the pupillometry. And you could study the size of the pupil. A constricted pupil is mediated by a parasympathetic nervous system. A dilated pupil is responsible for the sympathetic nervous system. And so you could take advantage of this. The problem is that the pupils respond to several stimuli, one being light. The other one is near fixation. So if you're focusing on something nearby, it constricts. And then mental effort, which is sort of mediated by both of these autonomic nervous system. And so when you introduce light, either red or blue light, you can see that the pupil size really starts to decrease and then rises up after you stop shining the light onto the eye. When you're focusing closing onto something, the pupil size decreases. And then for mental effort, on the other hand, it is only maybe 5% the amount in terms of magnitude of the response compared to light or near fixation. So when you're doing some kind of memory load, in this case, you're trying to remember the number of digits, and you can see for 3 to 5, the response isn't that significant. But then when you're trying to remember 7 numbers, the pupils dilate a little bit. And what's interesting for me here is that, it correlates a little bit with the number of how hard the mental effort is. So the more you have to remember, the greater the pupil size, although it's really the magnitude is not that much. And this is actually an average of 25 trials. What's also interesting to me is there's an anticipatory factor here. So you're anticipating before you see the numbers and you are already responding. So if you are able to control a lot of these factors like light or near fixation, and you're able to do multiple trials with a significant memory load or mental effort, then maybe pupil size is something that you'd evaluate, but it's highly inconvenient and very difficult to do. And the final one is heart rate variability. So to summarize, I think many have wondered, why are we focusing on heart rate variability? Why not some of these other options? And already by hearing some of the things that I've discussed to you, you can already tell that a lot of these are very impractical, only can be done, or many are invasive. And the other thing that is worthy of note is, this is the summary of the direct and indirect assessments, is that many of them, or most of them, are focusing purely on the sympathetic nervous system. And for instance, the neurotransmitter-based measurements, which measure catecholamine levels, we're not able to do this for the vagal system, is because the vagal system relies on acetylcholine, and there is a large amount of acetylcholinesterase in our bodies, which breaks down the acetylcholine. So you lose the ability to measure that into the blood system. And then there's also very few parasympathetic nerves that you can see in the skin. and sweat is largely mediated through the sympathetic nervous system. So a lot of this is predominantly sympathetic nervous focused. And the ones that are vaguely mediated are, this is microneurography, which is right by the neck, very difficult to do, again, highly risky. You can do the autonomic testing that's done in the labs by introducing various provocations, but it's inconvenient because not only you need to do a lot of these measurements, not only heart rate, but blood pressure is very important. If you can incorporate blood flow, for instance, blood flow to the brain, that would also significantly help it out. Those are things that are very difficult to do at home. So the options that are available for researchers like us that don't have access to many of these labs is basically two: electrodermal activity, where you could get the Sympathetic E4 or any other skin conductive devices. Unfortunately, they're very expensive. Or you could do heart rate variability. And heart rate variability is the only one that really evaluates the parasympathetic part, the branch, well compared. Electrodermal activity using these skin conductive devices don't measure parasympathetics at all. So that's kind of like the summary. This emphasizes why heart rate variability has been the focus in much of autonomic nervous system research and will probably be the focus for wearable research as well in the near foreseeable future.